Assalamu alaikum. Good afternoon, good evening, good morning, depending upon where you are. My name is Ravi Mamtani. I am a professor and vice dean for lifestyle medicine and population health at Weill Cornell Medical College in Qatar. I am delighted and have the honor of welcoming you to this very important session. It's a fantastic topic. And before we get into the topic and the introduction of the speaker, I want to go over some housekeeping notes. But first, a reminder that Population Health and Wellbeing series established by and launched by the Institute for Population Health was done with the following objectives in mind. Number one, discuss contemporary and critical topics relevant to healthcare, medicine, and population health. Examine evidence-based practices germane to public health and patient care. And then finally, describe the opportunities and challenges in the evolving world of healthcare and population health. A couple of housekeeping notes. One, your cameras and microphones are turned off. Please use the Q&A feature to type questions and comments, and questions will be addressed at the end of the discussion. Now, just for us to know that this activity is approved by the Accreditation Council for Continuing Medical Education in the US, and also by the Ministry of Public Health's Department of Healthcare Professions Accreditation Section, and is approved for a maximum of 1 hour of activity. Evaluation and certificates, a couple of points here. The post-activity evaluation will be available in your Cloud CME account by December 17, 2021. You will receive an email notification once the evaluation is available in your Cloud CME account. And finally, your certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. Now about the topic and the speaker. The topic for today's discussion is, as you can see, social determinants of non-communicable diseases, i.e. chronic illnesses, in the Eastern Mediterranean region. And to discuss that topic with us, we have an amazing speaker who I've known personally for many years, Dr. Hanan Abdul Rahim. Dr. Hanan is an amazing speaker. She's wonderful, she's knowledgeable, and an expert in this field. Now, I want to just briefly introduce Dr. Hanan, and then I will hand over the screen to Dr. Hanan. Dr. Hanan Abdul Rahim is Dean of the College of Health Sciences at Qatar University, the country's largest national university. She has a PhD in epidemiology and preventive medicine from the University of Oslo in Norway, and a Master of Science in Biology from Illinois State University, Illinois, USA. Dr. Abdul Rahim has over 20 years of experience in public health. She was the founding coordinator of the Bachelor of Science Public Health program at Qatar University, and one of the founding members of Qatar's first Master of Public Health program. And that's amazing. That's amazing. Between 2008 and 17, she was the Associate Director of the Social and Economic Survey Research Institute at Qatar University, the country's first academic-based survey research organization. Dr. Abdul Rahim's research interests include intersection of social science and public health, social determinants of non-communicable diseases, and the health of women. She has participated in a number of research studies and has authored a range of research and policy-oriented articles and reports in leading academic peer-reviewed journals, including the prestigious The Lancet, Health Policy, and Health Policy and Planning. Dr. Abdul Rahim provides consultations to health and development agencies, including UNFPA and EMRO WHO. She's also a member of several prestigious national health committees in Qatar. So with that, Dr. Hanan, I want to thank you for taking time out of your busy schedule to be with us this afternoon. And please join me in welcoming Dr. Abdul Rahim. Thank you. Over to you. And if I can just stop sharing the screen. Over to you, Dr. Hanan.
Thank you so much, Dr. Mamtani. Is my screen visible to you?
Yes.
Okay, fantastic. Well, first of all, allow me to thank you for this incredibly kind introduction from a very dear and esteemed colleague. I'm very, very happy to be with you this afternoon. So this is a topic that I feel very strongly about, and I'm happy to be able to talk to you about it for the next hour or so on the social determinants of non-communicable diseases in our region, the Eastern Mediterranean region. So I declare that I have no conflict of interest, no financial relationships, and no discussion of any unlabeled or unapproved drugs. And I think the audience might have had a chance to look at the learning objectives, but what I thought we would do this afternoon is to first start by outlining the most salient social determinants of health factors affecting non-communicable diseases and also the healthcare seeking behaviors in our region. I'd like to discuss a very sort of provocative idea of whether there is a role for social determinants of health screening in the healthcare setting, and to discuss that and to talk about the evidence and how far the evidence has gotten on the impact of screening. And in this case, we're really talking about the screening of social risks for health outcomes. And throughout, really, I'd like to be proposing the importance of policies that address the social determinants of health. So this is the cover of a seminal report that came out in 2008, and it was led by Sir Michael Marmot, who is practically the godfather of social determinants of health. And this report really called global attention to how important the conditions are that people are born, grow, live, and work and age in to their health outcomes, not just the access to healthcare and health system, but all of these conditions. And those are essentially the social determinants of health. And when we talk about the social determinants of health, we're talking about a number of factors, including what you see listed on the screen, things like income and social protection, things like education, employment or unemployment, and the impact of that on health, working life conditions, food insecurity, and the other factors that you see here on the screen. And I think that it's important to point out that usually they don't occur in isolation. They do happen to be clustered together, and usually, we are dealing with multiple deprivations at the same time that compound one another. And then, one of the items that you see listed here is structural conflict, and I will discuss this in the presentation because, unfortunately, it's a particularly salient factor here in our region. So this report, this very influential report, was launched in 2008. And at the time, the Director General, Dr. Margaret Chan, the Director General of the WHO, highlighted how important it was to look at the causes of the causes, right? So in the launch, she was quoted saying, "This ends the debate decisively. Healthcare is an important determinant of health. Lifestyles are important determinants of health, but it is the factors in the social environment that determine access and influence lifestyle choices in the first place." So again, taking us back to the causes of the causes, or the root causes. So that was back in 2008. And since then, there have been a sequence of regional reports on health equity and on the social determinants of health. And I'm showing here on the screen a very recent report. This is the report that focuses on our region, the Eastern Mediterranean region, also headed by Sir Michael Marmot. And what this report does is, again, it highlights the inequities in health. And by inequities, we mean the avoidable and therefore unfair inequalities in health. So it highlights the inequities in health and how they are shaped by the social determinants of health. And in turn, those social determinants are shaped by a larger environment, the political, social, and economic policies and systems. And the fact is that even though we are all probably all here in the health sector, most of what affects our health ultimately is happening outside of the health sector. So, reviews estimate anywhere from 30 to 50% of our health outcomes are determined by social determinants. And usually those are controlled outside of the health sector. And that's why when I said, I'll be talking about policies, really we should be emphasizing the health in all policies approach, because this is the only way that we can really be effective in impacting social determinants and therefore impacting health outcomes. And by health outcomes, of course, I mean mortality, morbidity, functional limitations, life expectancy, et cetera. So unfortunately, because of the inequitable distribution of resources and of the determinants of health, we find that there are vast differences, disparities in those outcomes. And again, the emphasis when we talk about inequities on them being avoidable differences. These are not fate, they are avoidable, and therefore their existence is unfair. So, on your right-hand side is a map of our region, basically. This is the WHO definition of the Eastern Mediterranean region, 22 countries. And then this report, the report that highlights the social determinants and the health inequities in our region, is basically, again, based on showing how the conditions of daily life, conditions like, where we work and how we work, and the conditions that people are born into, what happens in early life, our built environment, how those factors are influenced by structural drivers. And one of the most important, not the only one certainly, but one of the really important ones being conflict and the consequences of conflict, but other structural drivers as well to result in health inequities, unfortunately. And it's a pretty involved report. It's over 600 pages and it's publicly available. So please do take the time to look at it. It's the culmination of a lot of really good work. It urges countries of different levels of development in the region to do something if they're starting at a very sort of low level of socioeconomic development, to do more and to do better if they are already working on the social determinants of health. And I know that we're discussing mostly today, or almost entirely, non-communicable diseases, but it's almost impossible to not make a connection between that and between what is happening with COVID-19. And very interestingly, this is sort of an attempt to depict the road that we're on, starting with that 2008 report that I talked about, some regional reports in between, our Eastern Mediterranean region report released this year in 2021. And then we're headed towards a world report, Action on the Social Determinants of Health Equity. And the reason I mention this, as I mentioned COVID-19, is that what's interesting is that this report was called for by member states at the World Health Assembly because of the inequities that the world has finally understood thanks to COVID-19. So yesterday was the opening of the 10th Global Conference on Health Promotion convened by WHO. And one of the speakers, I thought, said it very eloquently when she said that COVID-19 gave us a live case study of health inequity. And I think seeing the impact, the differential impact it had on countries and even groups within the same country really brought to the forefront what the social determinants mean and how they can impact health outcomes. And as a result of that, member states have asked for a report that is due to be completed at the end of 2022 and then released to the 2023 World Health Assembly on the progress that's been made and what needs to be done for the social determinants of health. And in one of the sessions describing the report, the emphasis was really on action. What is the action that needs to be taken on the social determinants of health. So of course, assessing the burden is important, describing the situation is important, but the emphasis now going forward is on the action that has to be taken. And that essentially sets the agenda for the coming decade in terms of what needs to be done on the social determinants of health. So just to take a minute to think about what COVID-19 has done globally, but specifically in our region, and how it's helped uncover the impact of inequities, both globally and here in our region. The rate of COVID-19 infection and mortality followed the pattern of socioeconomic inequities. That happened globally, that happened in our region. So the risk of getting COVID-19 was following socioeconomic levels, but also what happens to people once they get COVID-19. Also, the outcome was determined by socioeconomic inequities to a large extent. The management measures that countries took, like testing, hospitalization, vaccination, also follow socioeconomic inequities. So we saw from the very beginning of the pandemic in our region, the highest testing rates were in the GCC countries, and they were lowest in the conflict areas like Syria and Yemen, where it was really very hard to know what was happening because of the very, very low resources there. Of course, we can't ignore the price that was paid in because of the containment measures. They were certainly necessary, but they had a substantial economic impact, and not all countries in the region were able to mitigate those consequences. So in the wealthier countries, the subsidies and support from the government was helpful, but in other countries, there was an increase in people reporting, working less hours, losing jobs, even eating less meals because of the impoverishment that resulted from the interruption to their work and because of the effects of those containment measures. And of course, inequities, like I said, tend to compound one another. So the impact was more detrimental for the poor, and it exacerbated other inequities that exist, such as gender inequities, and that was manifested in reports of increasing, for example, gender-based violence during the pandemic. And this is just an illustration from the report on the effect on poverty at different levels of poverty. And we can just very easily see that the proportion living in poverty at different levels has increased pre-COVID to what it was during COVID because of these various factors that we talked about: losing jobs, working less hours, etc. And before we talk about the non-communicable diseases, I just need to take a minute to talk about some of the data challenges that we have in the region. I'm not aware of any region that is completely satisfied with the quality of data they have. So data is always an issue in many regions. Our region tends to have issues with even vital registration, with birth and death registration. Conditions have been improving, so reporting on core indicators of health has been improving in many countries. But the fact is that we still have problems that are above the global average in terms of, for example, completeness of the cause of death registration. That is still lower than the global average, or knowing that about half the countries of our region don't report mortality disaggregated by the cause of death. So these are problems because if we're having incomplete and inadequate birth and death registration, then it's even more difficult to get data on various social determinants of health. We find that they are collected rather unsystematically and with variable quality. So a lot of times the data comes from small samples, subnational samples, data collected in different ways, in unstandardized ways, and that makes comparisons very, very difficult. Also, it's very important to have disaggregated data, and we tend to have that problem even within countries, not only between countries, but within countries. And although, when we think about describing and measuring the social determinants of health, disaggregation is not the only measure that we need to be taking, but it's a very important first step. So, you can't really tell when there are disparities if you lack the basic disaggregated data. So that's an issue that I think our region grapples with, and it's certainly something that has to be focused on going forward in the agenda on social determinants of health. There does tend to be more information in some areas than others. So for example, in early life, because of surveys like MIX and like the Demographic Health Survey and so on, we find that there is information. Usually there are data on maternal and child health indicators, but less so in other areas. And that's, like I said, that's very important to be able to document the disparities. So in terms of the non-communicable diseases, which are our focus today, I mean, it's not novel to say that non-communicable diseases are the main drivers of morbidity and mortality in our region. So 1 in 3 deaths in the region are due to cardiovascular disease, and NCDs are the main cause of death in just about every country in our region except Somalia. And I'll be talking about the variations between countries in a minute. The probability of a premature death, of dying between 30 and 70 years from a major NCD like diabetes, CVD, cancer, chronic respiratory disorders, is higher than the world average. So the 22% that you see here is higher than the world average, which is about 18. So this is what it looks like. The red is the regional average compared to the orange dotted line, which is the world average. So we are higher, and you can see that in many countries of the region that probability of dying in those ages from a major NCD is higher. I think what's also problematic in our region is that even once a person is diagnosed with an NCD, so take cancer, for example, the probability of dying is higher than it is for other regions. So for example, for cancer, the probability of dying from cancer is higher in our region, almost twice as high than it is in the Americas. And that has to do with a combination of factors, including late diagnosis and also to some extent access and quality of care. And finally, our region has the dubious distinction of having the highest age standardized rate of DALYs due to diabetes. And of course, as you know, DALYs are disability adjusted life years. So it's a measure of disability and premature mortality. So that's to say that we have a pretty high burden posed by diabetes, and that's the highest in the WHO regions. So the summary of this is that I know that talking about NCDs has receded somewhat recently because of the preoccupation with COVID-19, but the fact is they are a very significant driver of morbidity and mortality in our region. And what I'd like to do now is just talk about some factors, some of the social determinants that influence the NCDs, and try to give different examples. So it's going to be a selection of different examples rather than really focus on just one. So we have to start with what's really important and what is a very important determinant of health outcomes, and that is poverty and disparity. Right, so both. So poverty in our region is actually higher than was previously thought. So we do have a fair amount of that. And other than poverty, there's also the relative deprivation. So we have a range of income ranging from very high to much lower. And that's reflected in the health indicators of those countries. As I said, when I talked about the quality of the data, we tend to know less about disparities within countries, but there are significant disparities in income, although the disaggregated data is harder to come by. And our region tends to be high on the inequality scale. We are one of the regions that lead the world in economic inequality, so in the disparities between the wealthiest and the least wealthy. So on the left-hand side of this panel is our GNI, the gross national income per capita. And you'll see that the difference between the highest GNI per capita, Qatar, and the lowest is almost about 58-fold, right? So there is a huge range of income in our region. Income doesn't always necessarily translate into gains in development. So on the right-hand side of the panel is the Human Development Index global rank. And of course, you want your rank to be lower. That indicates a higher ranking, of course, right? So to some extent, it does mirror the income, but not entirely. So if you look at the bars, they're in two colors, orange and green. So the ones in green are ones that have not necessarily achieved the level of development that their income would predict, right? So the Human Development Index is based on measures of health and education and income. So those countries that are in green have not achieved on the health and education domains what would be expected of their rank. So wealth does not always necessarily translate into development. But again, the point is that we have quite a spread in our country, in our region. Now, one of the really salient features and very important structural determinant of health in our region is the conflict and the crises, right? So more than half of the countries in our region are affected by conflict and the consequences of conflict, like sanctions, like occupation, direct combat, et cetera. More than half the countries in our region are involved or affected by conflict. So even though we are 6% of the global population, we are far more overrepresented in terms of the refugee and the internally displaced population. And it is important to remember that when you talk about refugees, and displaced persons, you're not always talking about people who live in refugee camps. So many of them will live outside of camp settings in urban and semi-urban environments. And that, of course, also complicates our ability to get a clear picture on their health outcomes and on their living conditions, because they may not necessarily be living inside of a refugee camp. And of course, you know that in general, the effect of conflict on health is very, very large. So there are, of course, the direct effects, the deaths, the outbreaks of disease. So like the cholera outbreak that happened in Yemen, the polio wild type virus outbreak that happened in Syria, disabilities, mental health issues, which I'll be talking about a little bit later, food insecurity and malnutrition, and sometimes sexual violence that comes from sexual assaults associated with war and conflict. So there are some direct effects of conflict, but then there are also many, many indirect effects that create very unhealthy conditions for people. And that includes, of course, a worsening of living and working conditions, reduced access to many kinds of services that are needed, including healthcare, including education. Basic infrastructure is destroyed. And again, that has implications for communicable diseases, loss of employment and income. So people spiraling further into poverty, damage to the environment. And of course, you know, when we talk about the effect on health behaviors, if you're in a situation of conflict, then survival is your most immediate need. And that's not necessarily conducive to trying to improve your health behaviors or to stay away from risky behaviors. So the price that our region is paying for the prevalence of conflict is very, very large. This is just an example of, this is an infographic by The Lancet. So The Lancet commissioned a series on Syria specifically. And this is an example of what conflict does to healthcare. So this is very directly affecting healthcare, whether it's through the killing of healthcare workers or through the exodus of healthcare workers leaving the country. And so very few left to actually tend to people's health needs, destruction of healthcare facilities, and of course the impact on that is going to be felt for a very long time. So the impact of conflict on healthcare in many ways is very important, and in our region it's certainly very, very salient. But conflict also, other than the direct destruction of the healthcare system and all the direct effects we talked about, it's also a very important factor in mental disorders. And mental disorders are a significant burden in our region, probably more than people expect. So the mental disorders contribute to about 16% of years lived with disease in our region. So that's a measure of non-fatal burden. It doesn't kill you, but you live for a long time with this disease burden. So 16% of years lived with disease, with depressive disorders and anxiety disorders ranking third and ninth. Again, a measure of non-fatal burden. And that is certainly higher than other regions. It's higher than many countries at the global level, and that happens to be consistent across all income groups, higher for women than it is for men. And then in the bottom table, what I wanted to show was the effect of conflict specifically on the burden of mental health. So in a systematic review for the WHO, comparing the age-specific years lived with disease in conflict areas versus the usual, the global burden of disease 2016 measures. So the contribution of conflict, or the burden on mental health, is huge, as you can see, where the years lived with disease are at least sixfold higher for depression, and also manyfold higher for anxiety. So again, the toll of conflict on mental health is very large, and unfortunately it happens to be more so in the adolescents. So this was found to be even more so in the adolescent ages, and of course that does not bode well for future. Another aspect of care that is somewhat complicated by conflict, and that's severely compromised by conflict, another example is cancer care. And so with cancer care in the refugee population, you have a number of issues. First of all, just to even try to measure the burden of the problem. So first of all, for refugees, a lot of times they are not included in the official statistics, and they are not followed by the surveillance systems of host countries. So it's very difficult to track their diagnosis, their treatment, and their outcomes. So that is one of the issues. Also, cancer care can be very costly. So if we think about most recently Syrian refugees who have gone into Jordan, into Lebanon, into Turkey, the cost of cancer care has been very high. Initially, Jordan tried to absorb that cost within its national system, but it was too high. So that's something that host countries cannot deal with. One of the reviews found that refugees tend to present even later than the national population with their symptoms or with their diagnosis, because they don't know how to navigate the system and how to access preventive services. So already being a refugee or a displaced person already is placing you at an even greater disadvantage when it comes to cancer and the prognosis for cancer. Again, the issue of funding from the UN Commission for Refugees. And I think one issue that is becoming increasingly important, because now with the conflict, so many countries in the region are dependent on humanitarian aid. Non-communicable diseases, although that is gradually changing, are not usually an area of focus for humanitarian aid. Usually the focus is much more so on emergency conditions, but increasingly there's a call for the need to screen and treat and prioritize non-communicable diseases, including mental health, in humanitarian aid. And I think when we think about the populations in our region that are affected by conflict and that are in need of humanitarian aid, and that could be because of conflict, but also because of natural disasters, I think it becomes apparent that we cannot ignore the burden of NCDs and of mental health in that population. Another example of social determinants of health outcomes in our region is, of course, gender inequality. So our region tends to have a host of or a range of gender inequality measures on the Gender Inequality Index. So some countries do better than others, and I certainly am not in support of stereotypical ideas about our region and gender. I really support sort of very nuanced discussions and studies of gender and its impact on health. And like I said, in our region, there is a significant variation. So actually, if we look at the Gender Inequality Index, it ranges from very high in some countries to much lower in other countries. And there are certainly efforts that are being done to address that. But in general, gender inequality leads to lower levels of, or is manifested in lower levels of employment for women, even though they've made very significant advances in education. And that, of course, is connected to their financial empowerment, and that's a very important determinant of health. Limited political involvement. So when we talk about policies that shape health, women are often not a part of those policies in many sectors, not just in the health sector. There's a high burden of caretaking within the families. We saw that in COVID-19, but we knew that even long before. So the burden of care is disproportionately on women. Their access to resources may be less, and that could be a very significant determinant of their health, as many studies have shown. Economic resources, social and human resources as well. So there's been some work done in the region. I've been part of some of that work on social and economic resources and their impact on perinatal health. And usually the gender inequality also is associated with higher rates of gender-based violence. And we saw an increase in reporting of gender-based violence during the COVID-19 pandemic, but also more generally the social norms around gender-based violence and whether it is acceptable or not. So when we talk about a determinant like gender, or a factor like gender, and when we think about some of the risk factors for non-communicable diseases, I think one of the examples that come to mind and that are often quoted is the example of physical activity. So the prevalence of physical inactivity in our region is really quite high, and some of the highest levels are in Gulf countries, but also in other countries in the region. And that's similar to global patterns. So globally, physical inactivity is higher in women than in men. So in that case, what are we using to explain that? This is a really interesting review that on physical inactivity and gender and culture that tried to systematically look at this question. One of the problems I will point out with physical activity in particular is that the measurements are so they vary across studies very much. So you'll find that different studies use different samples and different measures, and it's very hard to make comparisons. But any way you look at it, whether you're looking at a nationally representative sample or a subnational sample, whether you're talking about big surveys like the STEPS surveys or other smaller national studies, the fact is that inactivity is higher in women. So that line there is the male-female ratio. And so it tends to be higher in women than it is in men. And again, there are a number of explanations for that. Part of it has to do with the environment, which is also part of the determinants of health. Part of it has to do with general norms around physical activity and how important it is compared to other activities, and whether people find it worthwhile investing their time in physical activity. And part of it is indeed about gender norms. So the dress that is required for physical activity, restrictions on movement, what's appropriate movement in a public place, the availability of gender segregated spaces so that women can practice physical activity. So that can also contribute to physical inactivity, which is a very important determinant of non-communicable diseases. Another example of determinants of non-communicable diseases and how they're influenced by the social determinants are the trends in tobacco. And trends in tobacco are very interesting because this is an example where gender actually was protective for women through multiple pathways, one of them being that smoking cigarettes is seen in a lot of countries in our region as less acceptable for females than it is for males. And so we've always found that there is a gender difference, whether in adults or in adolescents, in the prevalence of tobacco use between men and women. So it's much higher in males than it is in females. But if you look at this panel and we start looking at the adolescents, those gender differences are actually not as big as they are in adults, meaning that there are now sort of shrinking differences between men and women in tobacco use compared to what happened in adults. And that could be, that's attributed to a number of reasons. One of them is the change in sort of the social norms around the acceptability of tobacco use, but it's also the type of tobacco that is being used. So what we're seeing now is an increase in water pipe tobacco smoking and in electronic cigarettes. And, you know, this is really interesting. Water pipe tobacco smoking and electronic cigarettes tend to not be as objectionable to some as cigarette smoking is, and so it's more acceptable for females. But you know, just to back up for a minute, I probably went over the slide too quickly. I don't think we can, you know, underestimate how important tobacco trends are in our region for the future of non-communicable diseases. So yes, there has been progress made in many countries in terms of legislation, regulation, but they're not enough. So we're actually not on track to meet the WHO's reduction target by 2025. The reduction in tobacco use in our region has been very modest compared to other regions, and that's really quite unfortunate, and again, does not bode well for the future of non-communicable diseases. But back to what I was saying about gender and types of tobacco use. So water pipe tobacco smoking is still more prevalent among men than it is among women, but that gap is smaller than what it is for cigarette smoking. We did a study here in Qatar where we found that water pipe tobacco smokers find that women are more comfortable using water pipes than smoking cigarettes. And then in another study of 4 universities in the region, colleagues found that public water pipe tobacco smoking ranged, to a high of 86.2 for females, and we can take that as a measure of the acceptability of water pipe tobacco smoking, so smoking it in cafes and restaurants and so on. And another study in Egypt also found the gender gap for water pipe tobacco smoking narrowing, and that it's higher for the electronic cigarettes, it's higher for females than it is for males. So the change in social attitudes and in the type of products of tobacco is actually going to be detrimental to women in the future. So what I've done so far is I've just trying to give you through several examples of non-communicable disease risk factors, how the social environment and how social and political determinants like conflict, like gender norms, impact the risk factors for non-communicable diseases. But I am mindful that mostly in this audience, I'm probably talking to many healthcare professionals. And so you must be asking yourself, is there a place for social determinants of health in the healthcare setting? And I will tell you that there are different views on this, on whether this is the case. There is the view that trying to deal with the social determinants of health in a clinical or healthcare setting might actually risk devaluing the social determinants of health or medicalizing them. So treating racism or conflict as though it were a disease and trying to deal with it in that way. So there is a concern that, you know, should we even be linking those two together when we're trying to expand beyond the health sector? And I can give you my view in a minute, but I'd like to just share other people's work on that. So some of this work, these attempts to address social determinants of health, are manifested by trying to screen for social risk factors. So if we think of, you know, social determinants of health, as I explained, are sort of very broad, right? So they're very macro level. I'm going to skip ahead just a couple of slides to explain this. So they're quite broad and they're quite macro level. So when we talk about social risk factors, they're measurable and they're intervenable individual level social and economic conditions. And they are, of course, shaped by the broader determinants of health. So the idea is to try to address the social determinants of health by looking at the individual level at social risk factors. And so what some of the healthcare organizations try to do is to screen for social risk factors. And this is a really interesting paper looking at how we can advance that field and hypothesizing what could be the ways, the pathways from screening for social needs to improving health and health equity and healthcare outcomes. Because let's remember that this is the desired end goal, right, is to reduce inequities in health and to improve healthcare outcomes. And we can hypothesize, and the authors here hypothesize that there are different ways that this can be done. So screening for, say, poverty, for food insecurity, for violence against the person, that could be important in alleviating health inequity or in improving healthcare outcome by reducing the patient's social needs. So you can connect a patient, for example, coming to healthcare to assistance, whether that's food assistance or protection from violence or any form of assistance. So that could help and improve outcomes by connecting the patient to assistance. It could improve the quality of care that is given to the patient, because I think healthcare providers more than anyone know that, you know, if you don't change the environment that a patient is coming from and you just send them out into the same environment, they're not likely to improve. So understanding that environment could help tailor care so that it is more possible for the patient then to comply with care and to take care of themselves. Other pathways include reducing stress and anxiety for patients, and also reducing the provider burnout, because it is very frustrating for providers to deal with social risks. So what should clinicians screen for, and is there evidence that this is actually helpful and that this has any impact on the health outcomes of populations? And again, I remind you that we're talking here about screening for social risk factors, which are shaped by the broader social determinants of health. So this was a review that was undertaken to support the U.S. Preventive Services Task Force, and it went through a large number of tools for screening for social risks and needs. And the summary of this review is that, yes, there are a large number of tools that are out there that screen for social risks. Mostly they screen for needs in housing, transportation, and food insecurity. Some topics also include interpersonal violence and financial difficulties. And I think in some areas of healthcare practice, there is more, it is more common to screen for violence or for suspected abuse. So, you know, in pediatrics or in obstetrics, they're slightly more used to screening for potential for violence or abuse, but not so usually in the broader practice. So there are some topics that are touched on. The biggest problem with these tools is what the review found is that they're not psychometrically validated, meaning that they're not tested for validity and reliability. So most of them were found to be quite pragmatic to use. So they're short, they're understandable, they're not too difficult to use. But without the psychometric foundation, it's difficult to use them for comparisons, and it's also difficult to use them in intervention studies. And what the review found is that most of the studies are not RCTs, so very few RCTs, mostly they're observational studies. And looking at the impact, there are not really a lot of studies that look at health outcomes. So did screening actually improve health outcome? A lot of times the outcome that is looked at in these studies is something like healthcare utilization. So is this making the patient come back less times, or is this reducing the need for admitting a patient rather than dealing with them in outpatient care? So that's different from saying that screening actually has a positive impact on health outcomes. And I would remind us that it's also important to be mindful of possible detrimental impact of screening in case that help cannot be provided. So that is the status of screening tools. Now, I've searched very diligently for tools to screen social needs in the Eastern Mediterranean region, in our region, because I think this is definitely something that that is very much needed. It's very hard to find those tools. And I think even more important is the fact that in order for screening to be effective and even ethical, we have to identify resources and to make sure that they are in place that the provider can direct the patient to. I mean, if you think about our fundamental conditions for screening for diseases, we always have to have a possible intervention. Otherwise, what is the point of screening? And I would say that it's same here, that it is possible to screen, but then you need to connect patients to resources. I think also it's very good to benefit from the literature that is available internationally, and there isn't that much of it. So this is very much an area that requires development. But at the same time, it's very important to understand what social risk means, or what constitutes a social need for the patient in question and for the community in question. So some risks and needs might be more salient than others. And then to think about what would facilitate their adoption. Of course, being short and easy to read for patients is important. Integrating them into health records, and that in itself can be very problematic when the basic medical records might be lacking. But how to integrate that information with health records in order for them to be useful, because the last thing you want to do is to burden healthcare providers with more data collection that is then not useful, not impactful, not beneficial. And of course, again, like I said, you have to be mindful of not causing more harm in screening than helping. So you have to raise awareness and create conditions for privacy and for protection from stigma. If you think about, screening for intimate partner violence, for example, and other factors as well. So for that particular area, what could be some recommendations that I, very humbly put forward. We need to educate and raise awareness among healthcare providers on the broader social determinants of health, and then what can they do to highlight social determinants of health. In service provision, I think we see this in some places more than others. We need to build capacity in healthcare-based social work. So sometimes healthcare providers are connected to social work, but in other places, those bridges need to be built and to be made much more effective. And in the area of research, we need to develop and validate tools for social risk assessment, and even more generally beyond the tools, just building that agenda, looking for the evidence, because you don't want to introduce something that is a burden and that is not evidence-based. So building the agenda for exploring the evidence for using social screening in patient management, social risk screening, and whether it actually has an impact, and on what outcomes does it have an impact. I have to say, I have to go back to Sir Michael Marmot, who I started with, with the 2008 report. And he's very interestingly wrote his views on how healthcare professionals can be involved in the social determinants of health. And if you read his articles, I think it's interesting that he himself acknowledges that it's strange to be talking about social determinants of health and healthcare professionals at the very moment that you're saying that a lot of what we need to do to improve social determinants is outside of the healthcare. Nevertheless, I think that there are a lot of really important contributions that healthcare professionals can make. Sir Michael Marmot identifies workforce education and training. So I think if we compare the conversation now around social determinants of health and what it was, 5 years ago, 10 years ago, we'll find that there's a very big change. So that in itself is a huge improvement. And continuing to educate the workforce on social determinants of health, I think, is a very worthwhile investment. Seeing the patient in their broader perspective, so understanding the community that they come from, because the deprivations in the community have a very real impact on a person's health and on their health behaviors and so on. So understanding the broader perspective, what is that environment that this patient is coming from and is going to go back to? That's very important. The health service as an employer, of course, especially if you're talking about public health services, they can be employers of a very large segment of the population. And we know that the conditions of employment have a very large effect on health as well. So the health services ensuring that they themselves are, as employers, are creating good conditions for health in terms of, physical risks, but also mental health of healthcare workers. Of course, there is no way that healthcare professionals would be expected to do any of this on their own. So the partnership between healthcare and between other organizations, whether it's civil society, non-governmental organizations, other governmental organizations, that's important. And in my view, I think one of the most important contributions that healthcare professionals can make to the social determinants is advocacy. In our region and all over the world, healthcare professionals are highly respected. They are valued, and I think they can use that status that they have in the community to advocate for the social determinants and to demonstrate their understanding and their appreciation of how social determinants can impact healthcare outcomes. And so just bringing this to a close, and I know that I talked about a number of different issues, but what I tried to show is that there are a number of examples from the region that demonstrate how social determinants of health affect non-communicable diseases and their risk factors. So not just the differential distribution of non-communicable diseases, but also the impact that they have on risk factors. I emphasize again that the policies and practices outside of the healthcare sector are just as important, maybe in some cases more important than what's happening in the health sector itself. And again, that's the importance of partnership. The health sector is a very powerful sector, a very important one, and hugely invested in health, but it cannot address social determinants on its own. Nevertheless, I think the healthcare sector can play a very important role in documenting social needs, in facilitating support for individuals, in partnering with community organizations, and definitely in advocating for health equity and for social justice. The evidence for screening for social risk factors, I think that's a very exciting area of research. I think the evidence is still unclear. It is the case globally, but I think in our region, it's still very much in its infancy, an area that requires a lot of development. So developing context-specific but validated tools that can be used so that we can also study the impact of intervening on them on health outcomes. And with that, I will conclude and say thank you and happy to take questions.
So once again, our gratitude and our appreciation to you.
Thank you for inviting me. It's always a pleasure to speak with you.
It's been wonderful. So thank you so much once again. And I want to thank the audience. Great questions. Thank you for interacting. And stay tuned, and we will be back with additional such seminar discussions. So thank you all. Dr. Hanan, thank you so much.
Thank you so much. Have a great evening, everyone.
You too.